Hello, everyone. This is Dr. Weaver. This is the promised voiceover that I talked about on last week. Um, as you know, we had a test and we weren't able to actually get to the shocks. We did actually talk about something that is part of your next exam, which is ABGs. So that was good. Hopefully, you guys have a good grasp on how to determine what someone's or how to interpret ABGs. So um, typically, what I do. With some of the concepts that we go over in complex. As you all know, especially in the beginning, I did quite a bit of lecturing because some of that material is just better to lecture to supply you all with information and quite a bit of it. And I have not really found a case study, that necessarily would cover all the material that I had gone over with you. Maybe it's a case study that I might have to make myself, which shouldn't be too challenging, but um, you know, that's something to think about in the future. At any rate, so the next topic we are going to be discussing is shock. I did uh, provide you with some voiceovers regarding shock. Um, when I when I do these case studies, they're actually case studies with NGN style questions, which is something you guys need because when you take your NCLEX and the next, um, uh, you know, not too far from here, if you will, then you want to know how to respond to these NGN style NCLEX questions so that you might be successful. In other words, it can't be straight lectures all the time. So I mix it up basically. I guess is the short way of saying it. Now, one thing I would tell you at the outset about shock is you might hear sometimes the saying, shock is shock is shock. That is true to a great extent, to the extent that no matter what the cause of shock is, essentially the cells of our tissues and organs are going to be deprived of oxygen and nutrients and so forth. And so now the cause of the shock is another story, and how you treat that particular cause is another story. And one example I'll give you of that is sometimes patients might have an AMI that severely injures let's say, the left ventricle. All right. And so we would refer to that as a cardiogenic shock. All right, because that left ventricle is not going to be strong enough to push blood out into the systemic circulation. And so what happens is that if the left ventricle can't do its job, then our cells and our tissues and organs, the cells of our tissues and organs, are going to be deprived. Now, but then let's talk about hemorrhage. Hemorrhage can also lead to shock. Let me back up. So, with the cardiac example I just gave, that's the cause of that is an AMI, and of course, one of the ways you fix that, of course, is by some cardiac medications. Um, Maybe the patient, in all likelihood, is going to need a heart cath with a stent, more than likely, and even possibly a CABG, depending on the severity or how many vessels are blocked. So a heart cath with a stent. So that's one way to, that would be the way that we would manage that particular cause of shock, right? And we refer to that as cardiogenic shock. Now, of course, if someone has, let's say they have a stab, they were stabbed or maybe shot, and they are hemorrhaging a lot, then that can also lead to shock. And how do we manage that? Well, we have to repair the injury, and we will likely have to give pack red blood cells and those kinds of things. So you can see where the treatments will be different based on the cause, but as far as how we, or rather, the fact that there is deprivation of oxygen and nutrients to our tissues and organs, and so in that case, shock is shock is shock because both of those causes will lead to a deprivation of or reduction in oxygen and nutrients to our tissues and organs. So, um, but again, it doesn't matter what kind of shock it is. These patients will still go through like 4 stages of shock, and again, no matter which type. Um, and again, it is how we treat it. That's where the difference comes into play. And there are some treatments that will still be very similar, right? So, for example, um, um, if somebody is losing their blood pressure because they're in shock, they're vasodilating, then whether it's cardiogenic shock or even hemorrhagic shock, then these patients may be on a vasoactive drip in order to improve their blood pressure. So they do share some commonalities as far as treatment is concerned. Now, let me go ahead and share my desktop. I think this is large enough for you to see. Let me see if I can increase the size just in case. Uh, no, I better go ahead and increase the zoomed. Oh, that's 250. I can't do 250. Um, hmm, should be able to go at least maybe 220 or something like that, but uh, maybe not. All right, so we'll leave it at 200. Hopefully you guys can see this. I actually provided this information uh, to you all. Uh, so that seems to capture everything that I want to see. All right, so let me go ahead and share this. So typically with these case studies, there are 3 areas that I like to cover before we actually go into the case study itself. And this is more or less a kind of a strategy or even a method that you guys should be following when you're studying, any of the disease processes and what have you. So as you can see here, and I think some of this is a bit out of order, but here it has the overview. So as you can see here, we'll be discussing cardiogenic shock. You have the overview here. You have the objectives here, which I think this should be discussed first. And then lastly, it will be the case study itself, all right, that we'll read through and then we'll pick it apart, of course. Now, there are several questions that we'll be answering as well. Let me just kind of show you what that looks like. So these are the types of questions, the NGN style questions. It's like 19 of them, right? So that's what that will look like. And we'll go through this in class. So let me go back. All right. So what I'm going to do is I'm going to look at the objectives first before I delve into the other information. All right. All right. So the first objective is to discuss the cause or etiology and pathophysiology of cardiogenic shock, and we'll talk about that. Prioritize the plan of care for a three-patient assignment. Prioritization is very important, of course. Like who do you see first? You're going to find yourselves, when you're at the bedside, working, where that would be quite the dilemma. Like, what do I do first, right? And of course, I've always told you to use the ABC mnemonic, if you will, because that would it basically tells us things that are more life-threatening is what we're going to tend to first. You'd be surprised how people can easily get sidetracked with things that have not are not as significant, and they ignore those things which are more life-threatening, or at least a harm to them to the patient physically. They may not die, but they may end up with significant injury because of your delaying. So, but we'll look at one of the questions about priority or prioritization. Also, evaluate results of diagnostic testing in a patient with cardiogenic shock. So, in any disease process, it is important for you to know which labs, which imaging studies are needed to aid in the diagnostic process. And it is that diagnostic testing that becomes a part of your assessment. All right. That will become a part of the assessment. The next one is identify relevant assessment data for a patient with cardiogenic shock. And of course, we know that perfusion deficits are going to be more prevalent. Remember, we talked about. I provided you all with a table that shows some very classic signs and symptoms of a low perfusion states. All right. So always refer to that. It doesn't change. Perfusion issue is a perfusion issue is a perfusion issue. So just keep that in mind. Um, Prioritize the nursing care of a patient with cardiogenic shock. And again, remember in prioritizing, we move from the most life-threatening to the least. So again, that example is ABCs, right? Um, Appropriately delegate nursing care of a patient with cardiogenic shock. And here you need to think about what the UAP can and cannot do. They cannot assess, they cannot evaluate, they cannot administer medications or anything that requires clinical judgment. They just cannot do. And so, really important for you to know because NCLEX sometimes ask you about those things. Since you are going to be the person in charge of the care of that patient, you need to be able to delegate safely and appropriately. All right. Accurately calculate dosage and rate for critical care medications, medication infusions. So I will be showing you how the problem was worked out for some cardiac drugs, because most of you do well in medication. So we probably won't spend much time on that. Although I do need to add some dosage calc to your test. I mean, I don't know what I was thinking. Um, Describe the interprofessional care of a patient with cardiogenic shock. So, what do we do for the shock patient? What is the actual nursing care? Um, so, all shocks will require reestablishment of oxygen, nutrients, essentially perfusion. How we treat each individual cause, again, will vary. I mentioned that earlier. And like I gave the example, a cardiogenic shock may require a coronary stent, whereas though hemorrhagic shock will require stopping and controlling the bleeding, blood transfusions, and so forth. And so, but though the commonalities amongst all of the shocks is that there's going to be a reduction in perfusion to our organs and tissues, which we'll get more into. The last one is select appropriate nursing interventions for a patient with hemodynamic monitoring. and intra-aortic balloon pump therapy. So now we are beginning to integrate those hemodynamic monitoring tools into this patient's care. All right. And so what do we do with those values and how to manage these devices? You know, the swan gas catheter, the A-line, all those devices, maybe even the ventilator, may all be appropriate for this type of patient. All right, depending on the severity of the shock that the patient is in. So that covers all of the objectives. All right, and so where we go next, and again, I just want to get this part over with so that when we could come back to class on Wednesday, we can just start on the questions. All right, so hopefully you guys take the time to listen to this voiceover before class, and that way we can go through the NGN style questions. It's interesting, kind of gets the whole class involved as well. All right, so let's take a look at the overview. Typically, your book provides you with an overview. It provides you with, and you should be reading in a rather top-down um, fashion, or you should approach it in a kind of top-down approach, where you're looking at, you know, that overview, and it may give you some anatomy and physiology for that system. And of course, you want to know what the patho is, because that's obviously not only will that help you on your HESI, but also it will help you to better understand the disease processes that we are dealing with. All right. And then, of course, it may go into the etiology, and then maybe your, you know, your signs and symptoms and so forth and so on, the interventions and what have you. All right. So, but you should go in a orderly manner. With these case studies, the overview will give us an idea of, you know, an abbreviated idea, if you will, but what's going on with this patient physiologically. All right. So shock is characterized, as you can see here, by decreased tissue perfusion, right, and impaired cellular metabolism. All right. And this results in this imbalance between the supply of and demand for oxygen and nutrients. So essentially, there is an increased demand. All right. There's a demand for oxygen, there's a demand for nutrients, but the supply is insufficient. And this is due to the fact that there is a reduction in perfusion of blood, which obviously carries or contains this oxygen and nutrients. So hopefully you understand that statement. It's pretty simple. You have this great demand, but the supply is decreased because you don't have blood perfusing. Again, look at the example of cardiogenic shock. Um, the left ventricle is not doing its job, and so you can't pump blood uh, the arteries to your tissues and organs, and so they starve. Now, cardiogenic shock occurs when dysfunction, of course, of the myocardium, um, caused by a variety of precipitating factors, and of course, this is going to result in a compromised cardiac output. Remember, the cardiac output, it should be between 4 and 8. And if someone has significant damage to the myocardium, then their cardiac output is going to be compromised, and our tissues and organs are going to starve and begin to die and go into dysfunction. Now, cardiogenic shock occurs when either there is systolic or diastolic dysfunction of a heart's pumping action, which results in a reduction in cardiac output. Also results in a reduction in remember the stroke volume. Stroke volume is every time the heart beats, right? You're pumping out about 60 to 120, I believe, mLs per beat. So all that is reduced, right? And of course, the blood pressure will fall as well because of that reduction in cardiac output. And remember what we talked about as far as systolic and diastolic dysfunction, right? Systolic dysfunction, the heart's inability to squeeze, and diastolic dysfunction, the heart's inability to relax long enough to fill with adequate blood so that it can be pushed out into the systemic circulation. All right. Now, these changes, of course, compromise even myocardial perfusion. Remember, I told you that so the heart's job is to pump blood not only throughout the systemic circulation, but the heart's job is also to pump blood to itself, right? And so if the heart is not receiving blood via the coronary arteries, then there's going to be further depression of the heart's function. All right, so the heart is not going to be able to function well because it too is not receiving enough perfusion to keep its cells alive and working and functioning well. All right. And so when the heart is compromised, then the cardiac output is going to be further compromised, and of course, perfusion is going to be even the more compromised. And then this is when we talk about the patient being in shock. Um, right. Now, your book should point to some of the different causes of cardiogenic shock, but I would tell you that one of the big causes, main causes, is an AMI. Now, the mortality rate for patients with cardiogenic shock is around 50%. So that's pretty significant. And it is the leading cause of death from an acute myocardial infarction or heart attack. And so, again, here you need to think about death of the myocardium or death of the left ventricle in particular. And this is what causes these patients to go into cardiogenic shock. And also, it's another reason why you'll see these patients requiring a balloon pump, because the balloon pump acts as the heart and helps to perfuse the body's tissues and organs. We don't go into balloon pumps very much because that's that specialized training that you guys will get once you go to an ICU. And so we just don't have that kind of time. And it's a bit more than what you need at this point. Right. Now, the heart's inability to pump blood forward is called, of course, systolic dysfunction. Again, the heart's inability to contract or squeeze. Now, this inability is going to result in a low cardiac output of less than 4 liters per minute. And of course, the cardiac index, remember the index, we add the body surface area, someone's weight, not believe height, but at least the weight of the size of the patient. And so that number will be less than 2.5 liters per minute. All right. One is just more specific to the individual. That's your cardiac index. But in other words, your cardiac index, cardiac output is going to be low as a result. Now, systolic dysfunction primarily affects the left ventricle since systolic blood pressure is greater on the left side of the heart because it supplies the entire body. All right. Now, the most common cause of, again, systolic dysfunction is an acute MI. Again, damage to the heart muscle that leads to inability of the heart to squeeze or contract or contract. All right. Now, the clinical manifestations of cardiogenic shock initially mimic those like someone who is in a heart failure. The symptoms are going to be very similar, all right? Because heart failure is a perfusion issue, and so it will look just like heart failure. However, the symptoms increase in severity as the patient progresses through the shock continuum from the initial stage, which we'll talk about, all the way to the final stage, or that final stage referred to as the irreversible stage. There are 4 stages. There are 4 distinct phases of shock. And of course, we will talk about each one of those and why it is important for you to be able to recognize what stage a patient is susceptible to, and be able to recognize what stage they are in, and more importantly, what can we do to stave off these progressive stages. All right. Um, I will say that in the initial stage of shock, you really don't see much going on because the signs and symptoms are very subtle, right? Um, in the refractory or the final stage, uh, basically almost nothing you do works, especially that final stage. All the interventions you can do, it's essentially futile, right? But that initial stage of shock is basically occurring because when see our cells operate in a healthy way as long as it has oxygen, because remember, as long as oxygen or aerobic or oxygen is available, then our cells go through what we call aerobic metabolism, right, because it has oxygen. And it during shock, then anaerobic metabolism kicks in, anaerobic meaning without oxygen. And of course, what is produced from anaerobic metabolism is lactic acid. So these patients go into lactic acidosis. And I'm going to show you all some symptoms or the different systems that are affected when someone is in acidosis, particularly metabolic acidosis. We'll talk about that. All right. Now, so let me say this again to you. What I want to do at this point is go over the 4 stages of shock. Now, the reason why these stages are important for you as the nurse is, well, first of all, um, you guys are being taught what makes the patient susceptible to shock, right? So just having the knowledge about the different etiologies or causes of shock should help you all to anticipate. So, for example, we know a patient, let's say I'm in the ED, and we hear over the radio, we have a patient coming in, and this patient, gunshot wound or maybe a stab wound, or we can already begin to anticipate shock. Patient comes in with an AMI, went into cardiac arrest and what have you. Well, we can pretty much anticipate that this patient may go into shock. And so we're already on hyper alert, right? In terms of knowing what are those different stages of shock, knowing what they are, but more importantly, being able to recognize the early stages of shock. You see, we can fix many things if we can catch it early in the process rather than late in the process. And you'll see with these different stages, once someone reaches the final stages of shock, it's pretty much game over, short of a miracle, right? So that first stage, however, as I said, is more subtle, right? And the only tool you have for that particular stage is your knowledge and knowing that, this can lead to this condition, whatever it is, can lead to shock. Someone comes in, let's say, with they come in with a condition that can lead to a septicemia, and subsequently septic shock, right? And so we're already anticipating, right? And so what they do, in particular for septic or septicemia, is that, and this is a Medicare or CMS thing. As soon as that patient comes in and you recognize that they have signs of SIRS, that's systemic inflammatory response syndrome, increased heart rate, low temperature. I think the blood pressure may be low with that. But there are different symptoms that we're looking at. And so they already start initiating certain therapies like and some of you may even know about this, especially if you work in the ED or maybe an ICU, but they start the IV fluids, they start giving the patient a bolus and give the patient, they draw blood cultures, they give antibiotics and so forth. So they're already anticipating, right? Because remember, in that initial stage, it's not as apparent, all right? There are these subtle signs and symptoms, but they're happening at the cellular level, because at the cellular level, that is where the cells are not receiving the oxygen and nutrients, and so these patients go into this anaerobic metabolism, and they begin to well, when someone is in anaerobic metabolism, when their cells go through that process, basically these patients, or rather our cells, begin to deteriorate due to acidosis, but it's a slow process, until, they really progress. All right. So let's go with the first or the initial stage. And so hopefully you guys understand why it's so important for you to know the stages of shock. And when we go through the NGN style questions, you'll see where there's some questions or a question that deals with what stage you think this patient is in. All right. So the initial stage of shock is a continuum. The continuum begins of this continuum of initial to the what is it, the final stage, a refractory stage of shock. That's the continuum. It just progresses, right? Unless you can intervene. But the continuum, it begins with the initial stage of shock, right? All shocks go through this initial period and progresses to the refractory. Refractory meaning, remember when we talked about ARDS, and when a patient, no matter how much oxygen you give them, the SpO2 levels continue to drop still, and we can barely get them up. Well, refractory in this case essentially means no matter what treatments you do, as far as a stage of shock is concerned, it's hard to get the patient back. All right. They're just deteriorating. They have multi-organ dysfunction and so forth. So anyway, so the continuum begins with the initial stage of shock that occurs at the cellular level, right? So there's nothing overtly visible that you can see, and you can say right off that this patient is in shock, because it's going on at the cellular level because of the increasing acid buildup. Right? This stage of shock, we always say that this stage of shock is usually not clinically apparent. You don't see any clear-cut signs and symptoms or clinical manifestations yet. Now, metabolism changes at the cellular level. Remember, I said it goes from aerobic, the availability of oxygen, to anaerobic, the availability of oxygen, and this causes that lactic acid buildup. This is something you guys probably remember from what is it? Microbiology. Remember the electron transport chain, all that craziness and whatnot. Anyway, so that acid buildup, that's what causes people when they don't have enough oxygen when they exercise, and they start cramping up, because you don't that lactic acid is what's causing the cramping and whatnot. But you don't have enough available oxygen. This is why you have to breathe when you're exercising, right? Now, lactic acid is a waste product that is removed by the liver. All right. However, this process, in order for the liver to remove this lactic acid, it requires oxygen. But remember, if a patient, whatever the reason for the shock, does not have that available oxygen, right? Then the lactic acid is going to build up. All right. That it's going to build up, and this is what's going to cause these different changes that will eventually become more overt, all right, more visible. So that's the initial stage. And again, what characterizes this stage is that the signs and symptoms are more subtle because things are happening at the cellular level. All right. But you can anticipate. You should begin to build that knowledge base in your own mind that there's certain conditions that can lead to shock. All right. Now let's talk about the compensatory stage of shock. So something is compensating. There's systems within our bodies that are compensating and trying to correct this imbalance, right? In this case, there are actually three different systems, mechanisms that are in place to try to correct this imbalance. So in the compensatory stage, the body activates the neural mechanism, compensatory mechanism, the sympathetic nervous system, in other words. It also activates the hormonal mechanism. And what does that involve? It involves epinephrine and also norepinephrine. That's the hormonal part. And all these are going to work together to try to bring about balance. You also have the biochemical um, compensatory mechanism. Remember the RAS, right? That's the biochemical, the RAS. Because if you have a reduction in blood flow to your kidneys, then the RAS system kicks in. Remember we talked about this with heart failure. Because of that reduction in blood flow, then the renin-angiotensin-aldosterone system is going to kick in order to try to overcome the increasing consequences of anaerobic metabolism in order to maintain homeostasis. Remember, as anaerobic metabolism kicks in because of a reduction in oxygen from shock, um, these patients physiologically, they're beginning to deteriorate, and all of these mechanisms will kick in order to try to improve the blood pressure, in other words. All right. So the clinical presentation begins to reflect the body's responses to the imbalance in oxygen and demand, oxygen supply and demand. All right. In other words, the signs and symptoms that you're beginning to see is going to become more apparent because there's this imbalance. There's this increase demand for oxygen and whatnot, but very little supply. And so the clinical manifestations are going to become more apparent. Now, a classic sign of shock, of course, is a drop in blood pressure, right? This occurs because of a decrease in cardiac output. Remember, whenever there's a decrease in cardiac output, for whatever reason, the blood pressure is going to drop, meaning your mean arterial pressure is going to drop. Then a narrowing of the pulse pressure will also occur because of this reduction in cardiac output. Now, something you don't really need to know, but it's good to just have an idea of what's happening here. There are baroreceptors that are located in our carotid area and also the aortic blood vessel bodies, um, which immediately respond by activating. So when these receptors are stimulated or activated, it is going to cause the sympathetic nervous system to be activated. And remember, with the sympathetic nervous system, what does it do? It is going to release these potent vasoconstrictors, the epi and the norepi, right? And this is going to cause this vasoconstriction. And it is this vasoconstriction um, that is going to improve just for a short time blood flow to the heart and also to the brain, um, because those are the more vital organs. And so that's what your body is trying to do. It's trying to keep alive the more vital organs, meaning the heart and the brain. So, but remember, I talked about the three compensatory mechanisms. And so that's why I mentioned the baroreceptors. that is located in the carotid and the aortic bodies. Once it detects that there's this imbalance, then the sympathetic nervous system is going to kick in and release these powerful vaso constriction or vasopressors, if you will, or vasoconstrictors, epi, norepi, and then of course we get better perfusion for a little period of time. But blood flow to the non-vital organs, such as the kidneys, the GI tract, the skin, and the lungs, is going to be diverted or shunted to the heart, to the brain. In other words, these organs, the rest of these organs, because blood is being diverted away from them to the brain and the heart, now they are going to start having issues. So, for example, if I'm not perfusing my kidneys, we know what happens, right? So the kidneys are going to begin to die, and urine output is going to be reduced. Also, if blood is being diverted from the GI tract, these patients, they tend to develop ileus, and ileus may be a small bowel obstruction. So the GI tract is just not working, right? Even the kidneys will begin to shut down on you because you're not getting much blood flow to your kidneys. And so then they go into a kind of dysfunction as well. Now the myocardium responds to the sympathetic nervous system and the increase in oxygen demand by increasing the heart rate and contractility. Right. So in other words, the heart muscle, it is going to respond. You know, remember that sympathetic nervous system mechanism. Um, Once it is stimulated, it is going to cause the heart's muscle to increase the heart rate, which will, temporarily improve the cardiac output and will cause the heart muscle to contract more. Again, these mechanisms don't last very long. All right, they're just temporary compensatory measures. All right. The other problem too is, remember I told you that the heart muscle itself is not receiving enough blood flow by way of the coronary arteries, and so that depresses the heart's function, of course. But remember also, because the sympathetic nervous system causes this increased contractility of the heart, it is going to require a whole lot more oxygen that it cannot receive. All right. Remember, decreased supply, increased demand. Right. Now, the coronary arteries, they also dilate to try to meet this increase in oxygen demand of the myocardium, but it's not going to uh, last very long. And all this is compensatory. The heart is just trying to achieve that balance. So that concludes the compensatory stage. And so you know what is happening in that particular stage: increase heart rate, but decrease in blood pressure. And so the patient is being maintained relatively fine. But if we don't correct the offending issue, it will progress to the next stage, which is what we will discuss next. So the next stage is referred to as the progressive stage. So you've gone from the initial stage, you didn't do anything, and then the patient's condition progressed to the compensatory stage. Well, now the compensatory mechanism is failing, and so now the patient has progressed to the next stage, which is again the progressive stage, and it is called a progressive stage. Now, the progressive stage of shock begins as the compensatory mechanisms fail. Um, there will be changes in the patient's mental status, which are very important findings in this particular stage. Not so much the compensatory stage, because remember, there's this increase in of the heart rate, the blood pressure is trying to improve perfusion and what have you, and so the brain is getting perfused. momentarily, of course. Remember, you got that diversion or shunting of blood to the vital organs, be that the heart and the brain. But in the progressive stage, as the compensatory mechanisms fail, the brain is not getting much in the way of the good blood flow, and therefore mental status change is going to be apparent in this stage. Now, these patients must be moved into the intensive care unit at this point for advanced monitoring as well as treatment. Now, the cardiovascular system is now profoundly affected in the progressive stage of shock. Why? In this stage, the cardiac output is going to begin to fall. All right. Those mechanisms we talked about in the second stage or the compensatory stage, they're becoming weaker or almost non-existent, right? They're failing. So the cardiac output will fall. And remember, I always told you when the cardiac output falls, the blood pressure is going to fall as well. All right. And there's going to be this reduction of perfusion to the coronary arteries, a reduction in perfusion to the brain, and also peripheral perfusion. So in other words, perfusion to our tissues and organs becoming further compromised. Now, these patients then begin to have this continued decrease in cellular perfusion. They're not getting enough blood flow to their cells. And this results in altered capillary permeability, right? This is another important feature for this particular stage. Because of that reduction in perfusion, the capillaries become more permeable, all right? They become more porous, right? And when the capillaries become more porous, all right, then this will allow fluids from the blood as well as proteins, those colloids, right? Proteins help keep blood within the vascular space, that first space. But when the capillaries are become more permeable because of this reduction in blood flow causing more damage, right, to our tissues and organs, then again the liquid part of the blood as well as proteins, right, begins to leak out into the interstitial space. All right, they leak out of that first space or the vascular space into the surrounding interstitial space. Right now, so in addition to the decreasing circulating volume, and the reason there's this decreasing circulating volume is because the liquid part of the blood is leaking out into the surrounding tissue, and so the vascular space is becoming more depleted. It's like a vicious cycle, and so as the vascular space becomes more depleted, you have less blood flow available for tissues and organs, and further compromise. Right? You'll when this volume leaks from the vascular space to the interstitial space, right? These patients become very edematous, right? So interstitial edema is going to be another prevalent symptom here in the progressive stage, right? Now, the patient may have a condition, what we call anasarca, A-N-A-S as in Sam, A-R-C-A. And what this means is the patient, you will see this very profound or diffuse edema because the patient is just leaking fluids everywhere, right? Because of this increased capillary permeability. So this fluid leakage from the vascular space affects, of course, solid organs such as the liver, the spleen, the GI tract, as well as the lung. And so they become edematous as well. And peripheral tissues will also, again, receive less and less perfusion because you don't have enough circulating volume. This volume is leaking out into the interstitial space. So think about edema in this particular stage and why. All right, remember, it's that altered capillary permeability. All right. So that concludes the progressive stage, and so the next stage we will talk about is the last and final stage, and this is the refractory stage. This will probably be the stage that you'll probably find a whole lot easier. This one in the first stage. The second and the third, which is the compensatory and progressive stage, they're not too bad either, because as you know, with the compensatory stage, things are still working relatively or somewhat fine because these compensatory mechanisms are you're trying to maintain homeostasis, but then they begin to fail, and so then there's this progression. Now the refractory stage, in the last stage of shock, which is the refractory stage, uh, decreased perfusion from uh, uh, peripheral vasoconstriction. Remember, the body is trying to cause vasoconstriction of the arteries in order to improve the blood pressure. Um, um, but then you have this decreased perfusion from due to that of the peripheral vasoconstriction, and also there's going to be decreased perfusion from that decreased cardiac output, and this is going to worsen that anaerobic metabolism. The anaerobic metabolism in this stage becomes even worse. All right. Again, due to that decreased perfusion, due to peripheral vasoconstriction, and also a decrease in cardiac output, the anaerobic metabolism, it gets worse. Now, the accumulation of lactic acid contributes to this increased capillary permeability and dilation. It causes the blood vessels, the arteries to dilate more, which means that your blood pressure is going to decrease even more as well. All right. And of course, there's this accumulation of lactic acid. These patients are essentially in metabolic acidosis. All right. Um, so you have this increased capillary permeability that is going to, again, allow fluids and plasma proteins to leave the vascular space and into the interstitial space. Blood also begins to blood pools in the capillary bed due to the constricted venules of veins and also dilated arterioles. So the venous system and the arterial system is impacted. Now, there's going to be a loss of intravascular volume. Remember that circulating volume we talked about? And because of that increased capillary permeability, the fluid part of the blood begins to leak out into our interstitial space and leaving the vascular space more depleted. And so this is going to cause the blood pressure to be even that much lower. All right. And when the blood pressure is much lower because of this increased vasodilation, the heart is going to try to increase in order to improve the cardiac output. And of course, there's going to be this decrease in coronary blood flow as well. And so the heart is unable to do its job, um, um, as the things get worse, if you will. All right. Um, And so again, as I said, that this decrease in blood flow to the heart leads to further myocardial depression and a further decline in the cardiac output. Remember, if you're not getting perfusion out into the systemic circulation, the heart is not getting blood from itself either. And of course, the heart's function goes into dysfunction, and our pumping action is going to be compromised severely. All right. And if a patient loses their cardiac output, you're losing your blood pressure and your mean arterial pressure. And so, you're not getting adequately perfused. Now, cerebral blood flow also cannot be maintained because of this. All right. And so these patients experience cerebral ischemia. Cerebral ischemia because well, I mean, you're not perfusing your brain. And so the reduction in blood flow to brain tissue causes ischemia. All right. And this will really eventually result in increased intracranial pressure, right? Because the brain, because of that insult, the brain is becomes injured as a result of a reduction in blood flow. The patient in this stage of shock now has profound hypotension and also hypoxemia, right? Because remember, when you have profound hypotension, then your mean arterial pressure is reduced, and now your vasculature, your arterial system cannot deliver oxygenated blood to our tissues and organs, and so hypoxemia becomes a significant problem here as well. The failure of the liver, the lungs, and the kidneys will result in an accumulation of waste products. Remember, the liver, it manages lactate. Um, it also manages urea as well as ammonia, and of course the kidneys excretes these products. The lungs, of course, we exhale CO2, which is a waste product, but all of these organs will fail, and so the accumulation of waste increases even the more. All right, now you got this multi-organ dysfunction. This is whenever you have more than one organ that fails, you got a major problem on your hand. All right. The failure of one organ system affects several other organ systems. And so recovery is unlikely in this stage, that refractory stage. And so the organs are in failure and the body's compensatory mechanisms are now overwhelmed. So prompt intervention in the early stages of shock may prevent the decline to the progressive or refractory stage. Interventions to treat cardiogenic shock is aimed at improving oxygenation and perfusion. Patient may need a balloon pump. Patient may need stents. They may obviously need oxygen. Um, all of this while preventing organ dysfunction. So drug and surgical therapies may be used to treat these types of patients. All right. So that's the overview. It's a look bit more in detail, but trust me, you need it. Um, and of course, I'm kind of debating on whether or not I should go over the case study, or rather do the case study now, or should I do it in class? Because that would make this presentation a little longer. Let me see how much time. So I got 58, so it's just under an hour. I think I'll go ahead and start talking about that, and hopefully, again, you get a chance to take a look at, take a listen. That way, again, we can just start with you know um, the questions itself. All right. So take a look at the case study here. This patient's name is LV. LV is a 68-year-old male admitted to the coronary care unit 24 hours ago with an anterior septal myocardial infarction. All right. Now, his past medical history includes two other MIs, and so that's important to note as far as the patient's history. But the patient has had two other MIs within the last 5 years. The patient is obese, hypertension, hyperlipidemia. This is all history, and also sleep apnea. Now, LV had, and that's not left ventricle, that's the patient's initials. Anyway, so LV had a chest pain at home for 12 hours before seeking medical treatment. All right. Now, the lab results note that the troponin is 5.2. I think that's nanograms per milliliter. So what I want you to note is that this patient has a pretty significant past medical history. All right. He has many high risk issues that lead to cardiac issues. even sleep apnea. All right. Especially if he did not use his BiPAP machine at home. Um, um, Also, I want you to think about the location description of the MI or that occlusion. Remember the EKG I showed you, and all of the different leads, and it shows you, what leads have to be blocked in order for it to be an RCA or inferior wall MI or an anterior septal wall MI. So just think about that. Think about that. Now, with respect to obstructive sleep apnea, I want to spend a little time with this because not only is this important for you to do patient teaching, uh, uh, warning your patients, encouraging them, if you will, that they really need to utilize this sleep apnea devices because of the problems that occurs when you don't use it, the health issues that comes about when you don't use them like you're supposed to. And so I certainly want to spend a little time with that because hopefully that'll spark in you this wanting to do a lot of patient teaching around it, especially for patients that tells you when they are admitted to the hospital, oh, I don't use that thing. It just it's too uncomfortable or whatever the case is. Well, if you guys are endowed with enough knowledge about the adverse effects it has on a patient, then maybe you'll be inclined to doing some patient teaching. So sleep apnea results in a lot of cardiovascular complications. Um, the apnea during sleep, when they're not breathing during sleep apnea, it causes hypoxia, right? This lack of oxygen to tissue, nocturnal arousals. So when they're sleeping at night, it causes them to wake up. So they're not really getting that quality sleep, right? And it also increases the pressure in the thoracic cavity. All right. Remember when I talked about when you have too much pressure in the thoracic cavity, it tends to affect your preload and your afterload and so forth because you don't get adequate perfusion throughout the cardiac system itself. Now, these events I just talked about can lead to some pretty negative physiologic consequences, including overstimulation or overactivation of the sympathetic nervous system. And so remember what happens with when the sympathetic nervous system or SNS is stimulated, you get the increased heart rate, increased blood pressure, everything is just hyper, the glucose levels are increased, and this is bad on the body, right? There's also increased vascular resistance. And so the arteries become very constricted, and so these patients develop hypertension. So now the heart is working even that much more harder to try to overcome that afterload resistance. There's also reduction in oxygenation of the heart muscle. We know that the heart is an organ that consists of cells, tissues, and whatnot, and it requires oxygen. And without that, the heart muscle is compromised. The muscles of the heart is compromised, and it doesn't work very well. Right. Now, the long-term effects include, of course, hypertension, which I just mentioned, cardiac dysrhythmias, because remember, less oxygen available to your cardiac conduction systems, those cells, will cause dysrhythmias, arteriosclerosis, heart failure. Remember, the heart is working very hard to overcome that increasing afterload, and also cardiovascular related mortality. And so they will die eventually of some cardiovascular mortality. I often tell students, even if this is obviously something that you want to talk to your patients about, but you guys may have family members that you love your family members and you want them to be as healthy as possible. So these are things that you want to talk to them about. All right. So also the troponin. What does troponin levels indicate? Right. Think about that. Uh, Myocardial what damage. Um, when the heart muscle, and that concluded the talk about sleep apnea. talking about the troponin levels now and what they mean. Whenever heart tissue is damaged, it leaks these enzymes into the bloodstream, meaning the troponin. And this is what when we do our cardiac enzymes, our troponin levels, it tells us how significant the heart damage has been. All right. Um, Again, it releases these enzymes. So the case study further says LV is currently pain-free with stable vital signs. The heart monitor shows sinus rhythm with occasional and unifocal PVCs and a heart rate in the 90s. All right. So remember, this is where I talked about those bizarre looking QRS complexes. And it could be due to irritability from a reduction in perfusion to the cardiac tissue. All right. And so in the electrical conduction system. And so you see these wide, bizarre looking complexes. All right. Further on, it talks about his blood pressure is 130/70. The respiratory rate is 24 breaths per minute. The oxygen saturation is at 93% on O2 via nasal cannula at 2 liters per minute. He has a heparin drip infusing at 12 units per hour and IV nitroglycerin infusing at 20 mics per minute. You are assigned to care for this patient as part of a two-patient assignment. Now, this last part is important because you have to learn who to provide care for according to priority, right? So we'll talk about that anyway, right? Also, I want you to note that the oxygen is needed to help improve oxygenation, right? Heparin is used to decrease the formation of blood clots, right? It doesn't break up current blood clots, but it prevents new ones from um, forming, right? It reduces or decreases the formation of more blood clots in the coronary arteries. So the MI will not expand, right? Because the more clots you have, the more death to the myocardial tissue will occur, and it will become larger, in other words. Now, the nitro, of course, is to dilate the coronary arteries to improve blood flow, but it can also decrease the afterload so that so damage to the heart pump will or the heart's pump will be able to push blood out into the systemic circulation with better ease. In other words, all right. So that's the case study, and I think that's enough with that. I'm going to end the presentation at this point because um, let's see, because this is what I want you to be able to take a look at before we come or take a listen to before we come to class, and that way we can just start with the questions, and you'll find that they're interesting, to go through as a class. And so this was like an hour and 8 minutes, so I don't think that's too bad. You got a lot, and this will help you as you listen to the other shock presentations or read some of the information I have for the different forms of shock. Um, and this is something you'll see in an ICU setting quite a bit, especially septic shock. So I think that's about it. If you guys have any questions after listening to this voiceover, don't hesitate to reach out. Thank you.